Welcome everyone to our HSPN monthly webinar. This month we have How Are OHTs Advancing in Digital Health? We have a fantastic lineup for us today. Please, as you're coming in, you can type into the chat, open up the chat box. Please type into the chat to everyone. Make sure you click it away from host and panelists, click to everyone, and let us know who you are and where you're joining us from today. And I see we are 1 minute in and have over 100 participants already with us. So I'm expecting to see this chat opened and live. Maybe we could just double check that people have access to the chat. We've had there we go. Anthony Zuppinger, Jennifer Borg, Jeannie Borg from Waypoint Center, Cecilia Craig from Durham OHT, welcome. Louise from Frontenac, Lennox and Addington. Tina McBride, digital health lead from Muskoka. Lovely. We have many digital health leads. I took a quick look at who had signed up for our webinar today. Paul Wanka calling us in from Montreal. Welcome to Omar Bela from Obela. I think I said that right. CBI Health. Sorry if I didn't. Liz Naughton from Ontario, somewhere in Ontario. Or from Naughton, Ontario, maybe. Hello, Samuel Garcia Feliz from Toronto. Welcome. Please join in. Let us know. Pop into the chat and let us know who you are and where you are joining us from, because we have people from all over Ontario. I know many people. Stephanie Hutton, eConsult from Kingston. We have many people I think had signed up also from the eCenter for Excellence in Digital Health. We have people from all across Ontario joining us today and from further abroad as well. And we have also just absolutely brilliant speakers with us joining us today. We're so excited about today's event. I do like to start, as we always do, with an acknowledgement of the land that we are coming to you from. So I am speaking to you from the University of Toronto, and I just really like to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, the meeting place is still home to many Indigenous people from across Turtle Island. I am grateful to have the opportunity to work on this land, and it really is a great pleasure and honor to be able to make this recognition to our the original people who lived on this land and continue to live on this land when we joined. If we were to go to the next slide, one of the things we like to do is to find out how many people are joining us here for the first time versus whether you've been here for a previous event. So I would just ask if we can open up this poll for people to respond to right now, and we could let us know if this is your, have you joined us before? Yes or no, this is my first event. Waiting for that poll. There we go. And for people to pop in here. And I am super enthused always that we continue to attract a new audience. I was just going to count up. I'm sure we're into 40 or 50 webinars at this point in time. And it is just absolutely great that we continue to bring people back and also attract new audiences depending on the topics that we are speaking to. So we'll give it just a few more seconds for people to finish answering in here. Definitely the vast majority of people. We also like that people reach for their keyboards and start thinking about how they're going to engage with us throughout the event today. So keep your chat box open because we will be using that quite a bit as we engage and find out what's been happening, not only with the people that are speaking today, but also with all of the people participating. Perhaps we could share at the poll now. If we were to have a look at the poll we have here, 72% of the people joining us today have joined us before, and 28% it's your first event. Congratulations on joining us. I think we have a really amazing event lined up for you today. I just want to introduce the people who are going to be speaking today. We have first off, Dr. Andrew Sarta, who's an assistant professor in management at York University and an honorary senior research fellow at University College London's Innovating Across Sectors program, where he works in partnership with our network. He's been researching early moments of change and how organizations innovate and adapt, and is perfect for today's topic. He's published in leading management journals and presented in several of the world's leading management conferences in this area. And Andrew is responsible for a digital health survey that we ran with the Ontario Health teams that he'll speak to. Then we have our views of what we've learned from you, but also really bringing live the experience from Ontario Health teams. We'll first have Christina Elishevsky, who's the director of the Cambridge North Dumfries Ontario Health team, where she leads a support team managing the implementation, decision-making structures, and oversees the accountabilities to the ministry. Christine has been involved in digital health throughout her close collaboration with the digital health lead, which has been Jeremy Howcroft, who is in the background today with us, and just transitioned to Angela Martin. Thanks to both of those individuals, as the transition occurred just as we requested their participation in our webinar. Strategically, Christina has been weaving digital health throughout the Cambridge North Dumfries OHT implementation structures to ensure it's been positioned as an enabler as they advance the OHT's vision. And then we'll hear from Victoria Chetty-Klebus, who is currently the Director of Integrated Care at the Algoma Ontario Health Team, and she holds a certified professional in healthcare information and management systems, so a true professional in this space. Her credentials from HIMSS and Coach, and also holds a certificate, certified associate in project management from the Project Management Institute. She's a published author in the fields of mHealth, health informatics implementations, clinical governance, and pedagogical technology, and she's been instructing in past colleges and universities across Ontario, and perhaps you'll run into her telling you about how to do digital health very well. Just, in sum, we have some of the brightest minds here today in understanding the development implementation of digital health in health transformation, and super well qualified individuals from, I'll say, bold OHTs. This is a trepidatious and dangerous space to walk in, and it is very, very difficult sometimes to advance in digital health, and yet absolutely essential. Andrew will talk about how we just really cannot do population health and integrated care without digital enablers. And so I'm sure you're as eager as I am to learn how the OHTs are implementing digital health. Like, really, how are they doing it? We know that you're in the audience, and we have leaders from many Ontario Health teams, academics, Ministry of Health, and Ontario Health. So I really encourage you and look forward to your engagement in the conversation. I am going to just start off with a quick little poll before we turn it over to Andrew. One more. And if you could just let us know, we can open up this poll, how knowledgeable you are at the outset here about digital implementations across Ontario Health teams. Give us a little bit of a baseline about our participants and audience today. Look forward to this poll popping up. And there it is. So please let us know how knowledgeable you are at the outset of today, and then we'll see how we're doing towards the end. And everybody's peppering in. We have almost 150 people online with us now entering into this. So thanks everybody for joining us. We really appreciate your participation and engagement. Okay, people are a bit quicker on this poll, which is fantastic. I think we could share out what the results were. And interestingly, if I scroll down here a little bit, I see I think there's one person who's very knowledgeable at there. So perhaps I look forward to hearing from you a lot. Most people being somewhat knowledgeable, a little bit of ideas in that mid-range. So let's see how we do over the course of today's webinar. I'd like to turn it over now to Dr. Andrew Sarta, and he can lead us through some of our findings from his survey. Andrew, it's over to you.
Thank you, Walter. It's really my pleasure to be here today, and I'm really looking forward to speaking to each of you and learning, and really to learn more about digital. We've started this journey with a survey out to each of you, and we want to share back those results to you. Walter introduced me, so I'll just go through quickly what we're going to cover today. So today we'll give you a sense of who the project team is and how we came at this, sort of where does this study situate in a broader context of other studies. I'll spend most of my time talking about the evolution of digital practices, and what we're really going to focus on is what was proposed and approved, and then what's happening at least up into the point of earlier this year. And so we'll look at that both within and across OHTs. And really the intention here is we want to engage. We want to engage in a dialogue. Walter alluded to this earlier. And so what we want to know is we want to hear from you as we present our findings. We're really looking to contextualize what what we're finding. And if you have insights, we'd love to hear them in the chat or through any questions. And in the end, you also hear from us a little bit of a plug where we're going to be looking to learn more from you. So we'll be refielding the survey, hopefully early next year in the winter 2024. And we want to gain a bit more data, particularly for those younger OHTs. So that'll be a little bit of a theme that you'll hear as I present my results. So without further ado, here's the team. Here's the team that's looking at this. So you know a bit about me. My partners on this are Dr. Angela Aristidou, who's a digital fellow at Stanford's Human-Centered AI Institute. And she's also an assistant professor at the School of Management at University College London, where I also hold a fellowship. And together, we're really management scholars in this space. So we look at things from a management perspective. And so you'll hear us talk a lot about practices and we'll talk a lot about organization. I'll preface this by saying we're not public policy scholars, we're not medical scholars. So we're really looking at this from an organization and from a management perspective to understand how these practices diffuse across OHTs. Walter is, of course, our partner in this study as well as the principal investigator for HSPN. And he really gives us the insight of OHTs on the ground that we use and we help to contextualize our findings. So where did this particular study of digital come about? So if we take a step back, this is really part of a global study on cross-sector collaborations in the healthcare sector. And the study is really in three countries, Canada, the UK, and the US. And I can speak mostly to the Canadian side of things as the lead of that arm of the study. And where we initially focus is in Ontario, and particularly with Ontario health teams. And a sister study to the one that I'll present today, focused on this notion of practices and activities, and I'll define that in a moment, but activities that OHTs were doing more broadly. And so what we're looking for is we looked at the transfer of activities between OHTs, some of the best practices that we found, and this wasn't just digital, it was everything. And we were encouraged by this idea that we saw OHTs innovating on the ground, developing practices that really suited local needs for their local populations. And we thought this was an encouraging sign where OHTs were almost filling in some of the gaps that were almost too broad for the province as a whole. So there was some element of this that was intriguing. But when we took a step back and we looked at this study a little more specifically, there was this curious consistency in the digital activities that were proposed. So the basis of that data was really the applications that were proposed and approved by OHTs directly and approved by the ministry, but digital activities largely look the same. And we thought this was a little curious, especially given the fact that OHTs had been approved prior to and after the pandemic, which is quite a disruptive event, and we thought digital would be impacted quite a bit. So our point of investigation started there, and we thought, let's look into digital a little bit further to understand what maybe is going on after proposal and into implementation. As we studied this, we took into consideration what the objectives were for digital broadly. What you see on the screen now are the objectives that are in the digital health playbook that many in Ontario would have received. And so there were three key objectives: offer patient-centered care, create more connections between providers, and be able to manage the system a little bit better through some analytics and some population health measures that could improve healthcare across the province more broadly. We kept these in mind as we began to collect data. And so then we went out and looked for data. And where we started were, at the time that we began this, we were looking at the first three cohorts of OHTs. So if you look at a timeline, we began all the way back to October 2019, which seems like ages ago now. And what we did was we made a choice to launch our survey to all the OHTs that were active as of September 2021. And we launched the survey, particularly if you look at the far right, in October 2022, and it was open until February to March 2023 or earlier this year. What that left us was three cohorts that we could analyze. We had cohort 1, 29 OHTs that were in existence or active for between 2 and 3 years at the time of the survey. we had cohort 2 of 13 OHTs they were active for about 2 years, and cohort 3 that were active for a little more than 1 year. And so what we wanted to do here was have an ability to compare across time where there was different times that had elapsed, and we could use this differentiation in time to be able to understand how time maybe impacts implementation in OHTs. And we asked a very simple question. We said, how have the digital practices evolved from the point of approval to the point of implementation? And so we kept this in our mind and began to design our study. And so as we designed, we started with this idea that we wanted to get a better understanding of what OHTs were proposing to do. So we looked at the applications, and we used the applications to extract what we call activities. And on the next slide, I'll define specifically what we mean by an activity, but we began by just pulling those out of the applications. What did the OHT say they were going to do when you began and when you received approval and you were planning how the OHT would function? We went through a validation step. So we used some computational techniques to validate how those activities might relate to one another. And again, I'll give you a little bit more about how this actually happens. And then, of course, we did the survey. And so we use those activities as a way to field the survey. So I'll dig into each of those sort of piece by piece just to let you know how did we actually get the data behind the study that I'll present to you. So I mentioned we start with an activity. In management, we define an activity largely as a set of actions. Or in this case, in this particular study, what did an OHT propose to do to implement a digital technology? And so these are sort of the on-the-ground activities. And what we did was we targeted the applications, looked at specific questions where digital was being asked, and we qualitatively extracted them out, and we kept the sentences or the paragraphs as verbatim descriptions, exactly as they were worded by the applicants for the OHTs. And then we coded these by hand and said, which activities are common and relate to one another. And we had groups of activities as a result. When we went through this, we ended up with approximately 14 activities per OHT with some differences across cohorts. So in cohort 1, there were about 15 activities for digital specifically, and in cohorts 2 and 3, approximately 9. Some of these can be attributed to the differences in applications for OHTs. We know that cohort 1 had a slightly different application compared to cohorts 2 and 3. But remember that what we're comparing is OHT to OHT, right? So what was proposed, and then for those same sets of practices, what was ultimately implemented and how. So then we start to, and I'll come back to this notion of practices, but we start to look for commonalities. And we used a language algorithm because we had verbatim statements to determine commonalities. So if language was similar, it would group into topics. And that was another clue to validate what we had coded by hand to say, yes, these activities belong together. We then took those activities, went back out to the field. We created customized surveys for each of the OHTs, and we asked them roughly 3 questions. For each activity, was it implemented as planned? Was it changed? And if so, why? Or was it not implemented? And if so, why? I mentioned when we surveyed the OHTs, what we received back were 21 responses from cohort 1, a pretty robust sample there, and about 5 responses from the OHTs in cohorts 2 and 3. And this is sort of me coming back to this notion of what we would really love to learn more from are these OHTs that have been active for a little less time. And that will really help us substantiate these findings a little bit more. Nevertheless, we'll present what we have from the cohort 1 and cohorts 2 and 3 OHTs with some implications for the differences between them. But that will be one theme that we'll talk through as we go forward. So one point is back to practices. I mentioned practices before. What you can do is you can think of practices as a set of activities. There are reasons why we want to do this. For one, if you think about verbatim activities like those 2 on the screen, which are real activities proposed, there's a huge variation between OHTs and which activities are proposed because they're quite specific to the OHT as a whole. It makes it quite difficult for comparison. So one technique that we use in management is to code these activities as a set of practices, common activities that relate to one another that create almost a bundle of activities. So when I say practice, I'm referring to a bundle of activities. What we would do is we'd look just like we do on the screen with these 2 activities, and we'd code these and say, expanding access to information through my chart or giving patients access to personal health information. These sound like patient data access. We do this by hand, and then we do this with an algorithm to say these words are related to one another. And we look across all of the activities, and we ended up coding almost 2,600 activities. So it can be quite a task for a researcher to code these. So the computational algorithm helps us validate, and we can have some confidence that these are indeed related to one another. So we did this for all of our activities, and what we ended up with were 4 practices. 4 practices are on the screen. They were reflected as patient data access, partner data sharing, virtual care, and data planning. Now, what gave us some confidence is these mapped actually quite well back onto the 3 objectives that were in the digital playbook, with one exception where we split out patient data access and virtual care because these seem to be different practices from the data that we had. And so what we're going to analyze in much of the results are these 4 practices and the differences in how they were implemented. Now, we're going to take a pause here for a moment because what we want to do is hear from you before we share the results in terms of what was successfully implemented versus what was most challenging to implement for each of these 4 practices. And so I'm going to put the poll up now, and I'm going to ask it to be sort of launched on the screen just to get a sense from the crowd of what you believe were the practices that we were most successful in implementing versus those that were most challenging. So 2 questions in one. The first is most successful, and the second relates to what is most challenging. So I'll give it a moment for those results to come in.
And just for people that they can scroll down, once you answer the first question, you can scroll down on that to get to the second question around challenges. So first is success, second is challenges. I don't know if you can see, Andrew, but we'll just keep it up in terms of the number of people. We have over 150 online now, and we're about a little past halfway on people entering into the pool. It's 2, so it'll take a little bit. Thanks to everyone for participating. And if you're in an OHT, this is definitely, you'll have some perceptions, but actually if you're just working with OHTs, you'll have your perception as well, and you're quite welcome to enter in that perspective. But we do realize that everybody won't necessarily have a knowledge about this one. Okay, I think it's slowing down, Andrew. So I think maybe I think it's Trisha has the poll or Nusrat to pop it open, and we can share back and let's see what the results are.
Okay. So I'm seeing most challenging, digital planning, partner data sharing, most challenging, certainly most successful. Looks like virtual care. Okay.
Yep.
Wonderful. Okay, so I think what you'll hear are some consistencies in that regard. And so here's where, again, we would love to hear more from you in the field. So roughly, I'll share 3 sort of core findings. First is when we compare across cohorts and we look at all the digital practices, we tend to see that cohort 1 largely implement their activities as planned compared to later cohorts. Again, we have more data there. We would love to learn more on this. We also do see later cohorts with some particular challenges that connect digital practices with some health equity challenges. So we'll talk through that a little bit. As we saw in the poll, partner data sharing certainly presents the largest ongoing implementation challenge for OHTs. So I'll talk a little bit about that in the second section. And in the third section, we do think there are examples of OHTs where partner data sharing can foster learning. There are some OHTs that seem to be able to implement this well, and that has ripple effects across digital specifically that can benefit integration as a whole. So we'll share those findings as well. So I'll start with the first finding, which is the comparison between cohorts. And I've classified these as initial results. Again, we want to hear more from those younger OHTs to be able to substantiate these to a larger degree. And if we just look at what was implemented versus what was not implemented, here's what we see. The green bar is what was implemented as planned. Blue is what was changed, and orange is what was not implemented. And there is a large difference between cohort 1 and cohorts 2 and 3 in terms of implementation as planned and not implemented. Now here, initially, before we actually saw any of these results, we were actually quite surprised to see this. It's a bit of a puzzle for us, and we're trying to substantiate this further. And the reason being was cohort 1, their applications were approved prior to arguably the largest shock we've seen in the healthcare system in a long period of time, which is the pandemic. And so having the ability to sustain and implement what was proposed, despite having gone through that shock about 6 months after approval, we were quite intrigued by and still are investigating and are slightly puzzled by. If there are thoughts in the chat and as to intuitions as to why, perhaps from OHTs directly, we would love to hear them. And so this is quite broad across all digital practices, but we felt digital would be quite largely impacted by in cohort 1. That didn't appear to materialize, and that could be a possible, maybe it's a good news story. Perhaps there's something more behind here, but more than 50% of the practices implemented as planned from those applications. Now, we do have some indication as to what might be happening here. And so when we look at the reasons why, and I'll explain the table at the bottom as a second. So we had, we're going to zoom in on virtual care, which is where we have most of our data across the cohorts. So the practice that we'll analyze is virtual care. The first column, the middle column you see there is the reasons for change were bolded as sort of a categorization of a reason for change. And the far right column is the reasons for not implementing something. Interestingly here, all cohorts have similar issues as reasons for changing activities. And most of the time, it comes back to what we've labeled as economizing. And this could be something in virtual care specifically, whereby you initiate a virtual care platform, you launch it, and it had several, say, bells and whistles associated with it. And when you went to implementation, you realized you didn't need all of those features. So it was either feature rich or perhaps too expensive. And there were some changes along the way that reflect some level of adaptability that OHTs were sort of economizing on, but still implementing. They're just modifying slightly. So we see some consistency. Now, what we also see is there's a greater implementation rate in cohort 1 compared to cohorts 2 and 3, despite having the same reasons. So here's where we think there's learning transfer opportunity number 1. Perhaps there's things that could be learned from OHTs that have gone through similar experiences with virtual care specifically that can be transferred along to cohorts 2 and 3. And again, any learnings here, any success stories, those we think we could potentially identify, and we would love to hear more directly from you. Now, differences emerge in terms of why virtual care was not implemented or why digital was not implemented at all compared to what was changed. What we tend to see as reasons for not implementation relate to far more complex issues. And so one reason that emerged was issues related to health equity. And here what we heard was credible and reliable access to internet or cellular data, where naturally digital activities and particularly virtual care rely on internet access and cellular access, particularly for remote communities. This was a stated reason that came back from the later cohorts as to why virtual care was not implemented. And that's a unique challenge. And in some ways, that challenge is broader than OHTs directly. So trying to do virtual becomes a little more challenging. That reason emerged far more in later cohorts than earlier cohorts. There were other reasons related to compartmentalized expertise. If Francophone expertise was in one partner organization, but perhaps wasn't in the primary care element of virtual care, then it became difficult to implement virtual care for particular populations. That was true for privacy regulation as well. So some reasons come through. Again, we would love to learn more about some of the implementation challenges here. And so early learnings, there's consistency in what gets changed. So there's some adaptability happening here, and we think there's a learning transfer opportunity from early cohorts to later cohorts that we could leverage to a greater degree. And there's also these larger health equity elements showing up. And I can see a little bit in the chat as well that there's some elements for particularly for rural OHTs that are difficult to implement when it comes to digital specifically. And that's where we wanted to put a spotlight on that to highlight that as an implementation challenge that may be beyond the scope of OHTs themselves and what can be delivered. So we're going to transition now. So these are the learnings from the first group of OHTs, and we'll transition to the practices themselves. So back to those 4 practices. And the ones we talked about: patient data access, partner data sharing, virtual care, and data planning. Where we have the data is in cohort 1, so we focused here. And so many of the findings and the findings for the remainder of the presentation will focus on those OHTs that have been in existence for greater than 2 years or between 2 and 3 years from the point at which they answered the survey. What we found was across the 4 practices, there were not many differences in terms of practices being changed. Where the largest differences emerged, and consistent with the poll that we just saw, was that practices differed in how they were implemented or whether they were not implemented at all. Let me rephrase that: whether they were implemented at all or whether they were not implemented. And that appeared to show up mostly in partner data sharing in that particular practice. And so the results, if we take out the changed element, and what you see here is green represents the practice implemented as planned, orange represents not implemented. And here you can see almost a reflection of what came back from that poll. Partner data sharing implemented as planned less than 40% of the time, whereas the other 3 practices implemented over 50% of the time. We can say there's enough data here that the difference is statistical, and we're confident that it's different, and the audience effectively validated that for us today. Now, it's not that this is particularly surprising. I think we could all reason that partner data sharing itself is the most challenging of all these practices to implement. And so we can still dig into the rationale provided by the OHTs, because there are some nuggets in here that, again, we think can foster some learning. So if we dig into the rationale as to why, and we provide some results, again, I'll explain the table and describe what you're seeing on the screen. Across the columns, there are the practices. I've taken out digital planning for expositional purposes and focused in on patient data access, partner data sharing, and virtual care. The first row are the activities under the practices that were implemented. The second row is what was not implemented. And then the rationale as to why is in the bottom. So if we look at patient data access specifically, what was implemented were self-management tools such as MyChart, Clinical Connect. These types of tools were implemented. There was approximately 1 activity implemented on average per OHT. What was not implemented were broader web portals or apps. These tended to be at a provincial level. And the rationale here was some of these were simply deferred to other institutions, particularly Ontario Health was mentioned in this case. So there was some rationale here in terms of who was accountable for this implementation, which is why it maybe wasn't implemented. If we go over to the right-hand column and we look at virtual care, what was implemented was virtual visit access, online booking. These tools were implemented. On average, about 3 activities were implemented. What wasn't implemented were expansions to this, such as expanding into home care or expanding into other providers, such as mental health institutions. And the rationale provided was managerial capacity. So this could have been financial capacity. This could have been a focus on other priorities. But it was mainly a prioritization element. Primary care was the initial focus, or online booking was an initial focus, and some of these other elements were still on the plan, but perhaps will be implemented a little bit later. When we look in the middle column, partner data sharing, where most of the challenges tend to be reflected, what we see is some OHTs implemented common platforms. They were labeled as clinical information systems. And on average, about half an activity was implemented. So most OHTs in this case, or there were many OHTs that didn't implement any partner data sharing activities. What was not implemented were the same types of activities. So we have commonality between what gets implemented and what doesn't get implemented across OHTs. And some of the rationale provided was scaling complexity or a lack of guidance. Here is where we think there's some potential for some of that guidance, at least, to come from within the OHT community themselves. And perhaps there's some learning and that can occur between OHTs depending on context. Of course, there are different contexts and different things happening at a local level, but there's some learning where OHTs have been successful in some implementations of partner data sharing that may be beneficial for other OHTs to learn from as well. And so what we tend to see as key learning here are partner data sharing certainly represents the largest challenges, but there are some OHTs that have had success with implementation using similar types of activities to other OHTs. So there may perhaps be, we believe there's an opportunity for some learning to be shared across the OHT community here. So what does this all mean here? And is there a way for us to qualify an amount of effectiveness related to these practices? So if there are struggles with implementation, is there anything that we can learn from here? And here is where we'd love to engage in some discussion. And so I can see a very active chat. And so that's fantastic. We'd love to hear more, particularly on this conversation of effectiveness. And what we're looking to learn from really is how you would measure and define effectiveness of digital implementation. So we have two questions for you, and I'm going to pause for a moment just to allow you to reflect in the chat before we share at least how we evaluated the first round of effectiveness when it comes to digital and how we defined it initially and whether or not we need to expand upon that. And so I'm going to pop up two questions on the screen for engagement in the chat. And our questions are this. When it comes to the effectiveness of a digital activity implementation, what is most important to measure? And second, what does success look like for digital specifically, and how will we know that digital has been successful in particularly healthcare integration exercises? I see Walter popping on. You want to add some thoughts here, Walter?
I'm going to help you with the chat here. I popped this into the chat just a minute ago so people could start to think about it. And one of the first items in is digital equity. And I did see someone earlier mention in some of the challenges in accessing virtual care in more remote areas that generally my telephone, I'll tell you in the city, it's generally my telephone as well. But equity, I think, is an important consideration across outcomes. And we have another response in here that's just patient outcomes, but I wonder about like which kinds of outcomes. What do we expect might be most affected by Ontario digital initiatives? One of our speakers, Christina's popped in to include both health implementation and outcome measures to thinking about progress. So Christina, you can speak a little bit more to this. Thanks very much. Tied to patient outcomes be most important because really it's digital health as an enabler to achieve these outcomes. And I'd support that as well. Equitable access, just the adoption, clinical digital adoption, and creating efficiencies. That's an interesting one to think about. Improve patient access to care. We have quite a few suggestions coming in here now, Andrew. So it's okay. I'll keep reading. Is that all right? Clinical effectiveness, communication effectiveness, and technical effectiveness. So I appreciate that reduction in issues during transitions. Data should flow from OHT to OHT without loss or patient risk. Wow, they're really coming in fast and furious now. It's amazing. Really happy from a provider's perspective as well. Digital supporting their joy and work. Lee Donahue popping in. The adoption, clinicians using it and patients accepting it. Colleen Lackey. And Jeremy Chad suggesting cross-system integration. So many different platforms and companies that need to talk to one another for this to be sustainable and scalable long term. And I don't know if some of our panelists later might weigh in on this a little bit, but I think about the notion of not trying to have every system develop multiple ways of speaking with every other system, but what are the standards that we can have and allow? And I know for those people who were around, and maybe you could look back to, we've had a few digital initiatives, webinars, often in partnership with IFIC Canada, where we've looked internationally at how other countries are setting up their infrastructure. Often it is this, create the standards that everybody needs to speak to, and then that allows the systems to talk back and forth, is to try and build, instead of trying to build specific interfaces, build some standards. And I know Dr. Carolyn Steele-Gray has some work in this. You might look back to some of the prior webinars. Most recent was last March 2023.
Fantastic webinar, yes.
So anyways, back here to some of these suggestions and outcomes, and then I think, Andrew, you might need to get on. Quintuple aim, not missing the provider experience, streamlining, Dirk Hugenwarning, Abby Regme, sustainability of the program, sustainable funding along those lines. So some people agreeing with the notion around having some standards in place that we can all match up to. And I think, that's probably a role for more provincial role. We probably can't have local standards being built across that. And what is the capability, and who can enact and enforce those to some extent? Anyways, Andrew, I'll probably turn it back to you. I think we've got quite a bit of input there.
Yeah, this is fantastic. Please keep the comments coming in the chat. This is, I wholeheartedly agree with the need for some standards, some way to, and this is part of our intention, right? How can we align at least on perhaps a set of ways to look at whether these are effective or not? I'll tell you how we classified it. Some of these themes emerged in the chat. Now, we did this qualitatively through the survey, and we asked again the OHT digital leads, and our definition was related mostly to integration. So what we asked about was improving patient handoffs, specifically the ability, and we came back to this notion from the original OHT guidance document that this was about navigating patients through the system. And so we asked the question in that respect, and qualitatively, we did this from a scale, 5-point scale, where 1 was very ineffective to 5 was very effective. Now, what we learned when we asked this, and we asked this for each activity that was implemented or changed, because you can't really evaluate something that was never implemented. We focused on only those that were implemented or changed. And so we had the strongest perceived effectiveness in patient handoffs for OHTs that implement partner data sharing. And what we were encouraged by was we see spillover effects for OHTs that implement partner data sharing to other digital practices. Put differently, for those OHTs that do implement partner data sharing, it has a halo effect across digital more broadly, and likely spills over to other practices not related to digital as a whole. And so this is, at least for our definition of effectiveness in improving patient handoffs. Looking at the raw scores, effectiveness of practice implementation for all practices on our scale of patient handoff effectiveness was about 3.6 out of 5, where 5 is very effective. And we see differences across each of the practices, where partner data sharing is highest at 4 when implemented. Virtual care is the lowest at 3.4. And that, we do think there's enough there to say it's different than the other 3. There's something going on there. And so we took our learning from the previous section on partner data sharing and decided to split our data based on those OHTs that implemented partner data sharing versus those that did not. And we'll share those results now. So what you see in our measure of effectiveness, the green bars represent 6 OHTs that largely implemented almost all of the proposed partner data sharing activities. We had 5 OHTs, and again, these are cohort 1 OHTs, that largely did not implement the practices that were proposed. And we compared the two and the scores across both. And what we see is systematically higher scores across the board, and particularly improvements in virtual care. And this is the spillover effect that I was referring to before. When OHTs implement partner data sharing practices, it does seem to impact the effectiveness across other OHTs. Now, I'll add a little caveat here on data that I did not show you. You'll notice that there are 10 OHTs that did respond to the survey that are missing. Those OHTs didn't propose any partner data sharing activity, so there's no implementation proportion that we could show, but we can evaluate their practices, and those do look a lot like the orange bars. And so whether it's proposed or not implemented seems to have similar effects on effectiveness, at least as surveyed by the OHT digital leads, compared to the OHTs that have implemented partner data sharing practices. So we do think there's some benefits here and some learning that could take place across the system, and that's going to be our segue to the next conversation, really. So those OHTs that do implement partner data sharing report higher across the board effectiveness ratings. Virtual care increases by the largest margin, but we do see increases across the board. And if we were to sort of sit back and hypothesize a bit as to why this might be, I think I've seen some of these comments in the chat already, but having data across partners, especially in virtual care where there could be more of a clinical focus, you can imagine that those clinical visits just might be of a higher quality with access to more patient information from more partners. And so the benefits may be revealing themselves there, although this is some area that we would love to dig into further and understand more, particularly from those in the field, in terms of why that might be the case. So in summary, we think there's some learning opportunities across time. Cohort 1 can potentially streamline implementation of digital activities for later cohorts, younger cohorts that have been active for less time. The health equity focus has come up multiple times. We do see that in the data as well, and we think there should be a spotlight on that and how that does impact digital implementation, particularly virtual care. And as we've talked about, discussed, and polled, partner data sharing certainly is a challenge. There are some examples in the system that we could potentially learn from, and perhaps some of those successful implementations are leading to effectiveness, at least as we've measured them and defined them so far. And so that, I think you've probably heard enough from me now. And so what we want to do is, rather than sort of an arm's length look at the data, we want to be able for you to hear from OHTs directly. And so I'm going to pass it back to Walter to introduce our 2 OHTs that are going to give you a little more of a spotlight on what OHTs are doing more specifically.
Well, it is my immense pleasure just to step out of the way as soon as we can get Victoria online with us here. And you can just see from this picture that's on the screen here, the massive geography that Algoma Ontario Health Team is considering and dealing with, and I'm sure I'm sure connectivity is an issue in some places, and so how do we leverage digital from that perspective? But then there's also backbone and what other aspects. So I'm really interested. We had some interesting pre-chat with Victoria around how they're thinking about digital in the north, and I think we have some awesome lessons to be learned here. For those people chatting in, just remember to make sure you're sending it into everyone. Sometimes it only goes to hosts and panelists, so people aren't seeing it. Victoria, let me turn it over to you now, and let's hear from you about your experiences and where Algoma is headed.
Thanks, Walter, and thank you, Andrew, for that wonderful presentation about that research. As I was listening to the results that the team found, I see a lot of reflectiveness in the work that we're doing and the challenges that we're experiencing. So hopefully this brings a little bit of perspective for OHTs on the call to say, we're all experiencing similar challenges, and this is what it looks like in Algoma. So as you can see from the slide, the Algoma OHT is quite large. We're about 32,000 square kilometers, which is larger than some European countries. And if you were to drive east to west, it'd be about 4 hours. Not on a day like today when we've gotten about 25 centimeters of snow, but for as geographically large as we are, our attributed population is about 103,000. So a very small population, centered around urban centers or large communities, about 75%. Currently, the Northeast, all 27 acute care hospitals are in the process of migrating to a single instance of Meditech Expanse. So as of early 2024, all 27 acute care sites will be on the same instance of Meditech Expanse. And that provides a bit of a context as to how in the North we think about digital health from a regional perspective, and that acute care tends to take the first step forward in terms of digital health and guide the region as to what they're doing. In 2019, Sioux Area Hospital, North Bay Regional Health Center, as well as West Parry Sound were the first acute care sites to go on the single instance of Meditech Expanse, and the rest of the hospitals will be going on, the other 24 sites will be going live in the next year. So this has been a huge focus of our acute care sites, particularly the 3 that are within the Algoma OHT. So lots of resources and capacity into that effort. We've also had another large-scale digital health project in Algoma in the last few years. So our group health center, which is a primary care organization serving almost 60,000 patients, upgraded their EMR. And so lots of capacity and lots of resources to support and move forward with their digital health projects. So as you can see in terms of the context as to where we are in Algoma the last few years when the OHT is starting to ramp up our work, we've really had our largest organizations focus on large-scale digital health projects within their own organizations. Therefore, our approach to digital health has really had to reflect that environment and the capacity available for larger digital health projects. Digital health has been a part of our work since the beginning of the OHT. We leveraged online appointment booking for our COVID-19 mass immunization clinics. We delivered over 70,000 doses of the vaccine through our MIC, and used that platform, the online appointment booking platform, to help support the administration of that work. That was in coordination with 17 other organizations within the community. So for many of our partners, that was really the first instance or the first iteration of online appointment booking that they had been exposed to. So back to that point that Andrew had made in terms of, you know, that some digital health or the cohort 1, even though it's happened during the pandemic, it afforded us these different opportunities to try things because of the environment that we were in. In continuation of that, and in collaboration with our primary care partners, we've leveraged funding for online appointment booking. So all of our primary care organizations that are AOHT partners are either live with online appointment booking or in the process of going live. To provide a bit of perspective as to how primary care is organized in Algoma, 90 to 95% of primary care in Algoma is organized into either a family health team model, a nurse practitioner-led clinic, or as I discussed before, the group health center model, which is our largest primary care organization. So this provides us with a great opportunity to have large impact on digital health implementations. Together with our partner, Sioux Area Hospital, we've also leveraged remote care monitoring to implement Seamless MD for post-surgical conditions. So hip and knee replacements, urology, minor procedures, and day surgeries. They will be, or Sioux Area Hospital in conjunction with Group Health Center and the AOHT will be expanding this platform for CHF and COPD discharges. And the extension of this digital health tool will align with our direction over the next year in complex chronic disease pathway development. This aligns with our overall approach of digital health progress. So rather than have several standalone digital health projects, we focused on attaching digital health advances with our population health management work. And this seems to be the most effective way for us to advance our digital health portfolio. So as an example, last year we implemented 2 pilots focusing on older adults living with frailty or at risk of developing frailty in the community. So the two main projects was the first, an early frailty identification pilot, and a coordinated access to geriatric services pilot. So with the early frailty ID program, we work closely with the Center for Effective Practice to build the assessment form that the clinician would use during that visit with the patient in Ocean Forms. And building it in Ocean Forms allowed the clinician to enter the information into the assessment form and that information to flip back into the provider's EMR. What we also did through that Ocean form was build in the appropriate navigations depending on how the clinician was entering information to the assessment. It would alert the provider to what the services for that particular need of the patient were. So if there was a need for nutrition, that information would populate into the form and ease that referral or that continuation of service for the patient into the community. This helped with some seamless transitions into care. And so to improve all of those transitions and, moving the patient between services, we developed a singular access form to support coordination among our specialized geriatric services. So we developed a paper referral form, but we also ensured that there was a corresponding e-referral available for local physicians. So our findings show that the paper version was definitely more popular of the two, but that we did receive a high volume of e-referrals instead as well. And so in the local context of Algoma, the Surya Hospital has kind of taken the lead in terms of implementing Ocean and using Ocean e-referral, and kind of pulling primary care along that way. So this was another way of introducing e-referral to the community. From a regional perspective, the 7 OHTs in the Northeast have worked together and collaborated on an initial project focused on episodic access to virtual care. So we are collaborating and sharing resources to design and support virtual care for those in the Northeast, and are currently in the design phase with implementation planned for fiscal 24-25. And over the first, iterations of community digital health projects, we've learned a lot about our community. And much of what we learned is helping to advance and contextualize our next steps. And, a lot of the findings that we've learned over the last, few years really align to what's, being discussed through Andrew and team's research. And the first is that organizations in our community still perceive digital health to be an internal operational portfolio. It's still very siloed. With not a lot happening in the community, but in terms of integration. There is an elevated risk adversity to sharing information and data between organizations. So again, aligned to a lot of those findings of that research. And that technological infrastructure is definitely more precarious than initially thought. Yes, in rural remote, we definitely have issues, but there's actually a lot of infrastructure issues closer to the urban centers. So what we've done in terms of helping to support some of that work, particularly for sharing information, is we initiated a privacy community of practice to support the foundations needed for information sharing. We recognize that many organizations do not have a dedicated FTE associated with privacy, while others had entire departments. So as a way to support the understanding of PHIPAA and increase capacity throughout the community, the privacy community of practice are developing strategies, sharing resources, and learning from one another. The other, next step that we're taking is actually connecting with a local primary care physician who has interest in digital health to start leading some of those digital health conversations and innovation within the community. So I'll stop there. That's, what's been happening in Algoma and some of the successes and lessons learned. I guess I'll pass it off to you, Walter.
Hi, thanks. I really appreciate lots of what you've been saying there. Particularly as you have a large area and being very local with those things that are best local, and being contextual, engaging with your patients, seeing what works best for them, engaging with your providers, seeing what works best for them so they can adopt. And I'm thinking back to some of the chats about we want patient adoption, we want provider adoption, and that needs sensitivities to where they're at and what best works for them. And yet thinking regionally, what do we need to put in as infrastructure so that everybody can have access and be able, again, my comment earlier, not just sharing one to one another, but sharing across the region. So I think you've been very astute in that, and perhaps it's your background expertise in this field that leads you to be that way. I'm not entirely sure. We're going to come back to a couple specific questions for you and the other two, but I want to hear from Christina as well first. So Christina, if you join in, great. And we can bring back up your slides, and I'll leave you on to talk a little bit about your experience from a different part of the province, Cambridge North Dumfries.
Great. Thanks so much, Walter. And big thanks to the HSPN team for inviting us to share our experience. And similar to Victoria, I found that the results that Andrew shared today really resonated with our own experience. And I've been watching the comments come in, and it's been very, very validating to our experience as well. But it feels at this point in the webinar that I'm almost doing an executive summary of what we've already heard. But hopefully I'll be able to share something a little bit new and a different perspective from our experience at the Cambridge North Dumfries OHT, and I'm coming forward with an administrative perspective and looking forward to sharing the on-the-ground experience that we have had, including our impact, our challenges, and facilitators as we enable our OHT vision with the advancement of our digital health activities. And I want to acknowledge my two colleagues who are on the line with me, Jeremy and Angela, who are our digital health leads. We just recently had their transition, and they have both been seconded from the eHealth Center of Excellence, and I just want to give the eHealth Center of Excellence a big shout out today, because we benefited tremendously from that partnership and that secondment. All right, so next slide shows you a little bit of context about the CND OHT to contextualize our experience. We are a cohort 1 OHT, and we are relatively small, as you can see by our attributed population that's under 150,000. We're located in southwestern Ontario, so we don't have as much snow as Algoma, but it looks like we're up to about 4 to 5 centimeters right now at this point. We have a mix of rural and urban geographies and an attributed population that's actually spread beyond our CND geography. We have over 40 members and affiliate members in our OHT, with only one non-academic hospital as a member. And as an OHT and community, we found that we have a number of facilitators and barriers to our digital health and advancement. So what we have going for us is that we have a lot of goodwill and trusting relationships that were strengthened through the pandemic experience. Given that we are quite small and a quite tight-knit community, we have quite a bit of nimbleness and willingness to try new things together. And we do have the eHealth Center of Excellence as a member of our OHT, which has assisted with our work. And we have a grounding commitment to digital health as an enabler to population health management as an OHT. This was identified early on in our application and was formalized as a component of our inaugural strategic framework in 2022. What we do not have is probably similar to many of the OHTs on the line, is significant digital health funding beyond the investment in the staff support resource to advance this work. We do have 2 priority populations that we are focusing our population health management work on, which is medical complexity in older adults and mental health and addictions, which is important context as we look at how we've moved digital health forward in these spaces. So on your next slide is an overview of our digital health plans versus reality. And this is a bit of analysis of our survey that was submitted as part of Andrew and team's research, just to share how this actually shaped up for our OHT. So when we look at our activities, we were ambitious. We submitted 27 digital initiatives in our initial application. And of those, in our analysis, 59% of initiatives were changed or never completed, while 41% of those initiatives were implemented and remain in use. So pretty similar to the averages that Andrew shared for cohort 1 OHTs. Obviously, we know that the pandemic experience changed the landscape in health. It changed the local needs, and also the lessons learned from the pandemic shifted our digital health priority setting. However, kind of digging deeper into commonalities across what we've pursued and then what we've not moved forward with, I did identify certain themes that I thought were quite interesting and again resonate with kind of that larger analysis at a provincial level. So for the initiatives that were not moved forward, what we identified is that some of those were actually pinning on specific solutions which have not moved forward or have been sunset and or are sunsetting. We are part of Ontario Health West region, and so my chart kind of shifting over now to Connect My Health. The other theme around those initiatives were that they required sharing of PHI between organizations and in particular with home and community care support services. And given some of the transformation efforts going on at the leading practices, that work has not proceeded locally. And finally, the initiatives that required allocation or reallocation of resources and licenses were not moved ahead. When we look at those initiatives that we were able to move forward with, what we found is that it, for the most part, leveraged provincially procured solutions. And practically speaking, that meant that we did not have to put an additional investment in those solutions. We could use free or near free solutions. Next, that it aligned with our priority populations. So we've been very deliberate with our population health management approach and tied the work that we're doing in the digital health space to those two priority populations. And those initiatives also built on existing partnerships. So leveraging kind of historical partnerships or integration and not requiring new data sharing agreements or that kind of legal element to new agreements. So on the next slide there, you can see kind of what we have been able to advance. And Victoria spoke a little bit to kind of how they've structured and embedded digital health as an enabler. And we've had a very similar experience. In our initial application, we actually committed to developing a digital health co-design group. And we brought that group together at our inception as an OHT back in 2020. And it did feel that we were trying to look for solutions for the sake of looking for solutions. And it didn't sit well with the group. They really felt that we needed to embed digital health in our population health management work directly. And so we disbanded our digital health co-design group and instead weaved our co-design or our digital health resources right into the groups that were facilitating those clinical improvements. And that served us very well. And so here you can see our 3 areas that we've been able to progress in. Online appointment booking has leveraged some infusion of funds through Ontario Health, and we've been quite successful in uptake in that space. Virtual care and secure messaging with a particularly good news story around how we've been able to consolidate our groups in this provider-to-provider secure messaging platform to enable cross-organizational secure messaging, which has been fantastic. And then we also had a really exciting, locally driven community mental health and addictions pilot project earlier this year, which brought together 8 or more of our partner organizations to co-staff a clinic offering a one-stop walk-in urgent mental health and addiction service. And this was a rapid improvement exercise with quite defined timelines and scope. And because of that, because it was kind of rapid and we were testing our change, we were able to mobilize our partners and establish these creative solutions to enable sharing of information for the purposes of the pilot. But what really surfaced through that experience was that digital health is a foundational enabler to providing integrated and coordinated care. By having these, and we like to call them kind of crafty solutions for the purposes of the pilot, we were able to facilitate collaboration and communication, and that led to a really unique and highly valued patient and provider experience in this particular project. And so now it's kind of turning our minds to what's that next step? What does that look like at a scalable and sustainable level, leveraging those lessons learned that we had through that CMAC project. Next slide, please. So Walter posed my question earlier in the chat, our question, I should say, about, where should these solutions fit? Where should these activities take place? And just acknowledging the realities of advancing digital health in a really dynamic and constantly transforming system with all of the pieces evolving at the same time. It's wonderfully chaotic to see the progress that we're making, but it's a challenging environment to navigate. And with limited funding at the OHT level, we've had to focus on being really judicious and strategic around our digital health focus. So we've had to adjust our priorities to add value alongside the work that's being driven at both a provincial and regional level. And in our circumstance, we've had this really interesting conundrum surface as we talked about some of the activities in the digital health space. What we heard early on from both our providers and patients is that a shared care record, or at the very least, a high level of interoperability, was a top priority for building an integrated health system. However, developing a local solution for this would add limited value in our particular OHT circumstances, given that, one, our patients in our community often seek specialist care outside of the Cambridge North Dumfries geography due to how specialized services are organized in Southwestern Ontario. So I'll give the example of a pediatric specialization. We take our children to Sick Children's Hospital in Toronto. We take our children to McMaster in Hamilton. We take our children to London. And so seeking care across OHT geographies. And then number two, a significant of our OHT attributed population, over 30%, live outside of our geography, with many of them residing in Kitchener, which is our close neighbor that we collaborate on a lot of our digital health solutions with, but also as far as Hamilton, as far as Brant, and we can assume that these patients would be seeking care, including emergency care, urgent care services in their own home communities. And so that creates a challenge. Should we be moving forward with these solutions that might not meet the needs of our community or our attributed population? So given these complexities, we've focused on local incremental improvements for our local population health management needs, monitoring both the provincial and the regional work, and anticipating, and I should say anticipating and really hoping that foundational digital health enablers, such as the integration of records, will be tackled at a broader systematic level for the benefit of our providers and our patients. And so I've offered you a reflection question similar to Walter's there around where should these foundational digital health practices be planned and implemented. And my final slide here, I feel like I'm coming in as a bit of a cynic by focusing on hurdles versus opportunities, but I imagine this is my opportunity to share and maybe commiserate with my colleagues so that we can find some shared solutions together. And because of transferring this from Canva, you can't see my beautiful graphic that was behind there, which was these hurdles that were kind of hopping over to reach that ideal state of patient data access, partner data sharing, virtual care, and digital planning. So the three areas that I wanted to highlight and, hopefully to initiate broader conversations and collective action towards are, one, the maturing in that dynamic environment and how we most effectively find the value of OHT work in that broader system that's evolving. The second is working within privacy legislation, and I saw that come out in the chat. Loads of challenges around how we navigate this at a local level, given that privacy advice at the level that we require is not easily accessible. It's very costly and quite time consuming. And so how do we navigate that balance? And then the awareness and access to data. We talked about partner data sharing and what that looks like. We did a bit of a count, and at last count, we have access locally to 15 data repositories at a regional and a provincial level that we can access to better understand our attributed population. And it's a bit of a sticky area because we have all this data, but it doesn't necessarily map onto our attributed population. It's a bit cumbersome to access. And so it's time consuming to tell our story and really to know where we go for which data we need and which story we're trying to tell. So that awareness and access piece at a kind of system level is challenging. And then at a local level is also challenging. We know that our members and our partners hold a lot of really rich data. But practically speaking, in our OHT, our staff are employed not by the hospital, which creates a bit of a barrier to really smooth access to hospital records, which we know are, at least in our experience, really, really rich records. And we have lots of goodwill and trusting relationships. And so we're working around it with kind of collaborative models, but it creates a challenge. So our kind of infrastructure creates a challenge to accessing that data. And of course, underpinning that is our equity considerations that run through kind of all of our digital health thinking and planning. And I've reached my 15 minutes there, Walter, so I will pass it back to you with that last reflection question.
It's an excellent question. And, you know, I'm a strong, always asking that question about to myself. And I have a colleague of mine in Alberta who actually stimulated that question for me provincially about how do we think about integrated care in general, as and many other aspects. I'll ask Christina now to come back on, and you know, got one or two questions now. I'll probably like to ask of you and see what your reflections might be. I do notice that there's a question in the chat that I hope we get to about that kind of relates to how we use digital capabilities for collecting data to generate evidence. It's a learning health system question. But first, I'm going to ask you, because I think, you know, part of the tone from today, and you know, you mentioned it there, and out of the partners in the audience, had a lot to do around this topic of data sharing. So I'm going to pick the hardest question first, because we might have limited time. And I'll ask about, you know, what your experience has been in managing that and trying to advance that a little bit in data sharing across partners. And I'll add a little flavor that came in from the participants today, which was a challenge. I don't know if you've faced it, the importance or the value and the challenge of sharing between health information custodians, which are those people who are, you know, in the province, for everyone who's not aware, covered under our privacy legislation to enable and allow for people to hold and share health information with non-health information custodians. So HICS and non-HICS, there was somebody who commented the challenge there. So first, just what your strategy might be. And Victoria, maybe I'll come back to you first and then come to Christina.
Thanks, Walter. It's a great question. And I don't think that we've quite figured it out yet. What we are recognizing in the environment is that the capacity or the understanding within different organizations is varied. So you have hospitals that are, you know, very resource heavy in terms of privacy, you know, offices and all of that great orientation. They have that bulk. And then you go to other organizations and they're like, I'm the privacy officer and I'm also the financial officer and I'm also the intake coordinator or whatever it might be, right? So they're wearing multiple hats. They don't have the opportunity to focus on it and really dig in. So in creating our privacy community of practice, we're trying to share those resources and make it a little bit easier for everyone to be on the same page so that we can have those conversations, those tougher conversations about sharing data. And everyone's kind of on that same playing field. So that's really been our focus at the start, is making sure that everybody is kind of on that same level and that same understanding as to what privacy is and how we can share information, you know, innovatively, but still protecting, you know, PHI and maybe being a bit creative about it.
A lot of ditto from me there, Walter. But what I will also add is we've really leveraged the why to encourage our partners to think about how we creatively share information. So we have a quality co-design group where we're really trying to tie the data needs to that kind of clinical transformation work. And when you put kind of that story ahead of the ask, ahead of the agreements, it creates that goodwill and that willingness to lean into the process, to lean into the collaboration. Oh, we don't hear you, Walter.
I don't often get caught on that. I think that's a great way of moving, right? Because I think sometimes it's easy for people to hide behind, sort of fear-based. And, when we talk to privacy folks, sometimes they say it's actually more perception than it is reality of what barriers there might be. And so if people feel the strong need and the value add, sometimes they find the way, even if some people think they might be breaking rules. We need to protect privacy, but sometimes the barriers are actually a little bit imagined. I am gonna, honor our audience questions here. So we have a few more if we have time, but there is a question around using data and digital capabilities for collecting data around your focus population. So, Christina, you were super clear about yours. Victoria, I can't remember. Are there things that you're trying to do about data to learn how you are caring for people with mental health or frail older adults that you're able to bring back to the OHT and leveraging digital capabilities to learn? You said you have access to many repositories. Maybe that's an aspect, or being able to bring those together a little bit. So this time, maybe I'll start with Christina and then go to Victoria.
I'm pondering this one because it certainly hasn't been a challenge, and we haven't kind of quite cracked this one yet, but trying to put, again, those structures in place so that we can at least identify what are the questions, like what do we need to understand about our priority populations? And those questions tend to surface directly in those clinical transformation working groups. And then who's at that table to capture those questions, bring them over here to our quality co-design group to unpack them a little bit more and understand where we get that data, then kind of bring in our digital health folks and see what levers can we use in the digital health world to make sense of the data or to grab that data and mine it. So it feels like a bit of a, oh, now I'm using like we're mixing a bit of a stew here to kind of bring together that story and understand our population health needs. So sticky, messy, but we're getting there as we kind of mature as an OHT, as we build up our structures.
Victoria, this might be something where, like, as we mature and start to think about what do we need to do for population health, we continue to get better at it.
Yeah, absolutely. And I completely agree with what Christina was saying about kind of trying to pull from here and pull from there and make sense of what's happening, because there are lots of gaps in the data, particularly when we think about primary care. That's probably our largest opportunity to understand our population better. And it's not as easy, to understand, to pull. EMRs are so different. And the way that the data is structured in the background. I did a couple years as a decision support analyst. So data is a bit of a passion of mine for sure. But we find that, acute care is very structured. It's coded. You have that sober second thought of coding going through and making sure that everything's accurate. So you're pretty confident in that. But by the time you're looking at acute care, it's really those proxy measures of the population. So you're not getting at the why, which is where you're going to get that understanding of what pathways, what digital tools would help prevent potentially that acute care visit or whatnot. So it's definitely trying to address right now. I think what we're focusing on, particularly with my colleagues in the Northeast, is really about those gaps in the data and understanding all of those pieces, primary care and equity, on where we need to move forward.
Thank you so much. And there's a few great comments in the chat, one around opportunities for new forms of health information custodians, and another about maybe we should just think a little bit more liberally. I like that in Ontario we have the Premier's might be the Health Minister's Premier's Health Council of Patients, and they have a patient declaration of rights, which talks about data being theirs and accessible data being theirs. And I think we haven't quite reached that, because when we reach there, it's much more easily able to transfer, I think, information between providers. I really like your points about starting where people actually access more of their care. There are like 1 million visits a day to physicians, and there are, no more than 1 million people in an entire year visit a hospital. where do people actually receive care and where do we need to actually be thinking about it? Thank you. We're coming close to time, so we're going to kind of lean back and start to close out here. I'm so appreciative that Victoria and her team and Christina and her team were able to join us here today. We are actually interested in updating some of our knowledge. Andrew, I just might ask you to talk about 2 of these points, and then we're just going to close out and see if we've advanced anybody's understanding.
Sure. Thanks, Walter, and thanks to Christina and Victoria. Really, really great insights from both of you. Our last request is we want to come back out to you, and these 2 requests are somewhat linked. So we're going to come back to a survey again on digital to update our findings and hopefully use some of the information we found here. That'll probably happen in about winter 2024. Don't exactly know the exact time frame just yet. What we want to really be able to emphasize is we see ourselves as kind of the megaphone. If we're doing our job well, we're reflecting what's actually going on in the field, and people like Christina and Victoria hold us to account to ensure that we're actually reflecting the opinions of what's happening out there. So when we want to be able to amplify some of those voices, what we would love to learn more from is some of the OHTs that perhaps are a little younger, where we had a little less data on that today, where we could maybe highlight some of those challenges and or successes back out to share again with you, to be able to hopefully have a continuing discussion on this topic of digital and how it can maybe continue act as an enabler to help integrated healthcare more broadly. So I'll leave it at that. We are very, very thankful. I'll pass it back to you, Walter. I'll skip by this thank you slide.
Thank you. And I popped this question into the chat, so if people mind to just close out with your thoughts on biggest priorities for OHTs as it relates to digital, and maybe we could just pop up the poll in the meantime, which won't take people much more than just a little over a second or so to click in, and just let us know, at the end, your current understanding. Have we helped to advance this a little bit in the province around your understanding of where OHTs are at? I think both through the chat and from our participants, if you can click into one of those options there and let us know. And also that idea of the chat of ideas people are thinking us, but if you have an idea, let us know what you think maybe priorities might be. And I can already see that our most popular bars moved from 5 to 7 up here on the side. We'll share that out in just a minute. We'll keep letting people maybe pop in for a few more seconds. Some nods. Okay, here we have some suggestions coming in. Digital equity and pop health. Let's keep the suggestions going. Andrew, if you move to the next slide, we can just let people know, reminding people that we are here almost every month on the 4th Tuesday of the month from 12 to 1:30. Really appreciate everybody joining us here today. We do take a break. The 4th Tuesday of December is on Boxing Day, December 26th. We will not be here. I hope you are enjoying time with your family or loved ones and enjoying your a little break. Perhaps you're still going to be in healthcare, working in the system on that day, but we'll be off for that day. We'll be back in January. We've been undertaking a series of projects specifically focused on equity. And for people who've been paying attention, we've already had 4 webinars on equity this year. We're going to start off the new year with another one around a range of topics as it relate to equity. These were actually questions originally posed to us to look at from the Ministry of Health. And we're going to come back and share them more broad because they're quite of relevance, I think, on Ontario. And in February, we continue our collaboration with the International Foundation for Integrated Care Canada. And we're going to be looking at some of our findings from HSPN. Guy and Boldenia and others on our team have been leading some understanding of policy supports for integrated care and OHTs in Ontario. And we have also been working with our colleagues at the North American Observatory to understand how this is being supported across the world. Thank you very much. Look forward to seeing everybody in January again. Feel free to get in touch with us anytime. I just had an email today suggesting a presentation or something that one of the OHTs might want to bring to the audience. We're very open to those suggestions. Anything that you think we can continue to be, as Andrew said, a megaphone for. That's our extreme pleasure. You see scan code now to share feedback. There's also a link in the chat to let us know how we did. We do look at these every single month and reformulate how we work, ideas for suggestions, and how we work out, and even how we bring people together and engage with our audience and participants. Thank you. Have a lovely afternoon from all of us here at HSPN. Take care.